COVID-19 showed that our healthcare system, our economy, wasn't as resilient as we had hoped it would be. And we've been, that has been a catalyst for a massive transformation in the healthcare system around the world. And better so in the healthcare system than anywhere else, because it was so obvious that the healthcare system failed us. Now, before I say failed us, I also want to say that a lot of things went really, really well during the COVID process in the healthcare system. We've seen massive transformation, massive innovation. The ability of the public and the private sector to work together in ways that were impossible before. And think about the telehealth adoption, I'm sure also in Australia, that we've seen the willingness to adopt telehealth that had been spoken about for years, but never done, was suddenly massive. Some doctors, switched 80%, 90% of their healthcare provision to telehealth.
We have seen a seismic shift in the uptake of digital health from Australians through COVID. We've seen it in a whole range of ways: telehealth, e-prescribing, but also in people seeking their information. And that's really changed the conversation, and that's why I think today and this moment is so important, because the conversation has gone from who's accessing my information to why isn't my clinician sharing it, and why am I telling my story all over again?
Yes, so look, most people who don't work in the healthcare sector are shocked, in fact, at how little we do share our healthcare data. And Jan-Willem made the point about there being identifiable or re-identifiable data, and then anonymous data, which is used for either research or quality improvement, and they can be quite different things. To Amanda's point, Australians as patients think it's happening already and are shocked when it's not happening. That's the first point. Secondly, and I'll make two important points here. One is, I sit on the board of the New South Wales Bureau of Health Information, and that is an agency that reports publicly on the performance of the New South Wales public hospital system. So you can log into their website and you can get reports on the performance of public hospitals across New South Wales. But 54% of elective surgeries in Australia occur in private hospitals, and none of that is available to the public. So there's also a transparency issue, a question here, I think, which is quite critical. And the last point I make is that I graduate PhD students who are analysts, data analysts, and they develop quite incredible skills and abilities working within Australian data that's very siloed. So we can have very good insights into the hospital system, but it's across the system that we're looking for. And yet they're coming out as graduates and they're working for companies that are being employed by other countries, Japan, the USA, to work on their data, which is much more connected. And our graduates are contributing to the improvement of their healthcare systems through insights and analytics that they can't do in their own country, in Australia, because the data doesn't allow them to.
Electronic prescribing, which is actually growing access. It's enabling there to be different models of care and people being able to access care in a whole range of different ways. Now, there's more to do. I absolutely agree with that, Adam. But I do think that we do have some of the foundations. What I think we now need to do, and where this is, it isn't a technology conversation, and I think we've heard that theme a number of times today, that the policy question now is what do we need to drive the kind of the guardrails, if you like. We've got foundations, but what are the guardrails, the change settings that are going to actually really kind of open this up, fast track it, and then enable that access to be far more ubiquitous, no matter which part of Australia that you're in.
We live in a large country, so we do have the tyranny of distance. If you look at the distribution of connectivity across the country, it's highly variable, and there's a bit of a double whammy to that. People who live in outer, rural and remote areas not only have fewer physical clinicians available to them, but they have less access to digital healthcare as well. Up to 15% less access, less affordability, and less ability to use digital access. So actually just getting it out there. So some of this is not about high tech, it's about actual reach and getting the tech there.
And for every condition, patients get an app to empower themselves. So here you go, you're a patient, you have diabetes, you get an app. And then you also are obese, you get another app. And then you have another app for the fact that you're pregnant, and you have maybe an app because you have high blood pressure. We really need to make this simpler for the patient as well, instead of having to log on every time, putting in their weight or age, their data records, all of those kind of things. So if we're starting to reorganize healthcare around patients and around care providers, it starts with the simple things like administration, workforce, and frustration, and manage those kind of things. And once we get those things, we'll measure the health outcomes. But the best health outcomes is that patients will feel empowered and they feel that they have control rather than get lost in app country and actually start to disconnect from the healthcare system. Because that's the biggest fear that we have, making it so digital and complex that it doesn't work for the patient, it doesn't work for the healthcare provider, it just works for the budget.
Healthcare data in Australia were actually established for administrative purposes, not for health purposes, including Medicare. It's still today largely administrative data set. The inpatient data in hospitals is much better and has much more rich clinical data. The richest clinical data comes from electronic medical records, but then you have to sometimes extract that through natural language processing and things like that, which is a great innovation that we need to develop. But the single greatest thing we could do is the thing that we've been talking about so far this afternoon, is link the data across from primary through to quaternary care, because at the moment we can get a good look into one silo of care, we can't get a good look across a patient's journey across the entire healthcare system. The virtual emergency departments that have been doing an amazing job around the country managing COVID patients, and they've exploded to the point that in Victoria they're seeing over 400 patients a day in the virtual emergency department, keeping them away from the door. I've seen the screens, and I've seen them where they've had 8 software programs open at a time, and on 4 of them don't speak to the other 4. So for those 4 screens, or those 4 software packages, the e-prescriptions and so on, they have to manually re-enter patient details into all of them. So A, think about the inefficiency of that. B, think about the potential for getting it wrong, writing in the wrong birth date or the wrong address or the wrong medication across all of them. So this interoperability question is huge, and not to be too cynical on it, and Amanda might disagree with me, but some of the inability for interoperability has also been partly a commercial decision on some of the software makers as well, because they would like to keep the black box to themselves. So there also needs to be some nudging and urging for this interoperability piece, which other countries have done, including in the US. You know, when Obamacare was rolled out, there were meaningful use requirements which required interoperability to be put in place. So I actually think the clinician or the clinical workforce, including allied health, are one of the biggest assets we have in this going forward.